Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred for a dislocated IOL. And not only the IOL, but there's a giant Sommering's ring. If the Sommering's ring is already dislocated, then it's not so difficult. But in this case, you'll see that the Sommering's ring is fairly intact. And to strip all the zonules and getting it out and trying to remove it is rather challenging. You're going to see me struggle through that in this case. And then finally performing my Yamane technique with the AR40 lens. So you can see this is the dislocated lens. You can see the posterior capsule is open. I'm going to dry the surface with a Wexel sponge and then ink the limbus with the 27 gauge cannula with the tip inked. Using the shaft of the cannula, I'm finding 180 degrees apart and then inking the limbus on the left side as well. Using the cannula to ink, to me, is the most precise way because you get those really discrete and fine marks. This is a fixed caliper from Epsilon. Again, I don't have any financial interests. You're going to indent 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. And you can see the indentation, and then you just mark those indentations. You do the same thing on the left side, 2.5 millimeters posterior to the limbus, indenting in radial fashion, and then indenting 2 millimeters adjacent, and then marking those indentations. Making sure it's completely dry before doing so. This is the back of the trocar needle, indenting 3.5 millimeters posterior to the limbus, and then tunneling around 3 millimeters towards that indentation, tunneling flat to the sclera to get a nice scleral tunnel, and then going flat and flush and entering. These are my incisions to help me remove that dislocated lens. This is my incision for the AC maintainer. And then this is the incision to externalize the leading haptic through a contralateral limbal incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the cornea. This is a 3 millimeter blade. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Using 2 microforceps, I grasp the haptic, popping it into the anterior chamber, grasping the optic, trying to locate the other haptic and then popping it up. Switching to the IOL cutters, I begin to cut the lens. Grasping the edge of the cut edge, pulling the left side piece out, and then Pac-Manning the other piece, rotating it. By cutting 90%, you're able to ensure that you get the whole thing out in one piece. Placing the 22 gauge thin-walled AC maintainer from Epsilon, performing vitrectomy. You can see there's a large Sommering's ring here. You can see it's moving, it's very loose, and so it has to come out as well. But to grab it is a little bit of a challenge here. Grabbing a Sommering's ring is almost impossible because it's just this very thin gelatinous material. There's no substance to it when you try to grab it. So I'm performing anterior vitrectomy through the pars plana trocar incision. And then I'm using a Lester to try to get under and around the Sommering's ring. And I finally get under it. And so now I'm under it, which means in that area there aren't any zonules, which is good. I'm going to get under it with the forceps. And then with 2 instruments, I'm going to try to pull it up. And as I pull it up, I'm able to tug on it, lifting some of the ring into the anterior chamber, but clearly there's some areas that are tethered by zonules, and that's part of the problem with this, is the zonules are holding on to the Sommering's ring. So it's a little bit of a challenge, but I'm using the forceps to essentially strip the zonules all the way across, and then using the infusion from the AC maintainer, I'm going to start burping the ring from the main incision. So there's one piece. Try to tease it, and then the rest of it comes out. Performing some more anterior vitrectomy. Trying to sweep because there's another fragment there. And then I burp it out. Performing some limbal vitrectomy as well. You can see there's a dollop of vitreous there at the incision. But I'm able to perform vitrectomy and remove that, release it. This is some intracameral triamcinolone. Unfortunately, there is no vitreous in the anterior chamber. Bending my needles. This is a right side needle, bending it about 90 millimeters from the tip. Bending it such that the bevel is facing towards the main incision. This is the left side needle, bend it at the hub, and the bevel is facing away. And this is the 25 gauge needle, bending it so the bevel is facing to the right to externalize the leading haptic. This is the emerald cartridge, injecting cohesive viscoelastic through the barrel and on the platform. And then placing the Sensor AR40 lens on the platform. Pushing it down so it's seated well. Bending the wings so the optic bends backwards. The trailing haptic comes out to the back, and the leading haptic comes straight out through the barrel. Placing it into the injector, making sure that the trailing haptic is sticking up outside the barrel so that the plunger doesn't touch it as you advance the lens. Okay, so here we go. 25 gauge needle through the contralateral limbal incision. The emerald cartridge injector. Make sure that both bevels face each other, the needle and the injector of the IOL. Docking the haptic on the bevel of the needle, trying to align both of the instruments, the haptic and the needle, in three-dimensional space. My assistant advances the lens, and more of that haptic goes into the needle. I withdraw the needle, and the haptic comes out. A passive externalization technique. Deliver the optic, sweep the trailing haptic to the right, externalizing the leading haptic a little bit more. Pushing dispersive viscoelastic to coat the cornea and pushing the optic back. Holding the trocar cannula with the forceps, turning on infusion, stabbing the conjunctiva and sclera at the first mark, flattening out, staying nice and flat and parallel to the scleral tissue, tunneling 2 millimeters, and then diving down. Using smooth microforceps to grasp the trailing haptic. Sliding it to the left so it minimizes any tension on the haptic. Docking the haptic on the bevel of the needle. 2 pushes, and then I'm in. Disengaging the needle from the syringe and then laying it down. Internalizing the leading haptic. with counterfixation with the forceps holding the incision, stabbing the conjunctiva and sclera at the first mark, turning on infusion, tunneling 2 millimeters, using that counterforce to ensure that I'm tunneling through the sclera through the entire length of the 2 millimeters, and then diving through. Grasping the leading haptic. Because it's away from me, the action, even though the lens is tethered on the other side, it's pretty easy still. 2 pushes and I'm in. Withdraw both needles partially, and then withdrawing the left side needle completely, limiting how much haptic comes out. Drying the surface, and then cauterizing the tip to create a flange. You can see the flat positioning of that haptic flat to the sclera, which means I have adequate scleral support for the haptic. Pulling the right side needle out in similar fashion, limiting how much haptic comes out. You can see how well that needle grips the haptic. I struggle to pop out that last bit. That's why I never worry that it's going to fall back into the eye. Again, nice and flat. You can see the haptic is nice and flat to the sclera on both sides. I'm just showing my staff how flat it is right now here. All right, nice and flat. Yep. I'm going to go ahead and push both haptics into the eye, pushing the flange flush to the sclera on both sides, and then reapproximating the conjunctiva. This is a 10-0 nylon suture to close the main incision. And this is a surgical PI. Again, you want to create that PI similar to when you would do a laser PI, which means you should be able to visualize the iridotomy. You shouldn't push the vitrector all the way into the angle because you'll hit the ciliary body and cause a lot of bleeding. Some more pars plana anterior vitrectomy. I'll hydrate my incisions, take the trocar cannula out and the AC maintainer out, and that's the end of the case. So again, this is a patient with a dislocated 3-piece acrylic lens. I Pac-Maned the lens out. There was a giant Sommering's ring. A little bit of a challenge to get it out because remember the ring is still attached to the zonules. Even though it's loosely attached, it's still attached. So it's really difficult to pull it out because you can't really grab the Sommering's ring. You can't use forceps to grab it. So instead, I used 2 instruments to kind of hook around the Sommering ring, lift it up, and essentially strip the zonules all the way around from the ring. And then once I got it up into the anterior chamber, I was able to burp the ring out using the infusion pressure. And then I performed my modified Yamane technique, externalizing the leading haptic through a contralateral limbal incision with a 25 gauge needle passive docking technique. This allows me to attack the trailing haptic with much greater ease. I'm able to dock the haptic on the bevel of the needle. I stab the conjunctiva and sclera with the needle, the 30 gauge thin wall needle, and then I tunnel 2 millimeters, staying nice and flat before diving in. And then very carefully, using smooth forceps, I'm able to dock the haptic on the bevel of the needle. And only 2 pushes is all I need because the needle grips the haptic so well. I never worry about losing the haptic. Performing the same thing on the left side, the leading haptic. Once the trailing haptic's in, that's the hard one. The leading haptic is much easier. Why? Because the working action is away from me. It's easier visibility. And because of the way I do the surgery, again, turning the needle to face the haptic, minimal trauma and stress to the haptic. I'm able to dock the haptic on the bevel needle. Again, a couple of pushes is all you need. Limiting how much haptic comes out as you pull the needles out, cauterizing the tip. And even though this pupil wasn't super big, I was able to do the technique without any retraction. Of course, Sometimes when the pupil is really small, you need some pupil retraction. But the biggest thing with this case was that giant Sommering's ring. And to get that out was, again, a challenge. And I don't think there's any really easy way to get rid of those giant rings. But I think in this case, definitely important to get rid of it since it was just flopping around in the eye. You don't want that lens material to cause any inflammation either. So go ahead and inject some subconjunctival steroids and antibiotics. And that's the end of the case, and the patient did well. So I hope this was helpful to you. And I thank you for your attention.